Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS, Diploma Programs, Diploma in Critical Care Nursing, DCCN, BNS, 03 to Nursing Management in Critical Care Conditions, Block-1 Care of Critically Ill Patients with Problems of Gastrointestinal System, Unit 4 Acute Pancreatitis, 4.0 Objectives. After completing this unit, you will be able to enumerate the various causes of acute pancreatitis, explain the pathophysiological changes leading to various signs and symptoms in pancreatitis, discuss the role of nurse in various diagnostic tests, describe the role of nurse in collaborative management of a patient with pancreatitis using nursing process, and advise patients to prevent the potential complications after pancreatitis. 4.1 Introduction. In Units 1, 2 and 3 you have learnt about acute gastric, intestinal and hepatic conditions. In this unit you will learn about acute pancreatitis. The pancreas is a gland which produces two main types of substances, digestive juices and digestive hormones. Digestive juices include enzymes and bicarbonate. They travel through a small tube called the pancreatic duct to the small intestine, duodenum. There, the enzymes break down the proteins and fats in the foods that we eat to permit the nutrients to be absorbed. The bicarbonate neutralize stomach acid. Digestive hormones, mainly insulin and glucagon, are released into the bloodstream. They control the body's blood sugar, a major source of energy. The pancreas may get inflamed due to various reasons. Once the gland becomes inflamed, it may lead to swelling of the gland and surrounding blood vessels, bleeding, infection, and can thus damage the gland. The digestive juices become trapped and start digesting the pancreas, autodigestion of the gland itself. If this damage persists, the gland may not be able to carry out normal functions. Pancreatitis may be acute, short-term, or chronic, long-term. Acute pancreatitis can be a life-threatening illness with severe complications. Most people with acute pancreatitis recover completely from their illness. The pancreas returns to normal with no long-term effects. Pancreatitis may however reoccur if the underlying cause is not eliminated. Patients with acute severe pancreatitis may be admitted in ICD directly. The patients may develop pancreatitis as a complication of another disease, surgical procedure, or trauma. It accounts for 10% of all patients with episodes of pancreatitis. The patients with severe pancreatitis usually die as a result of infection, pulmonary complications, or hemodynamic collapse. As a critical care nurse, you have to be prepared to provide quality care to such patients. This unit will focus on definition, etiology, pathophysiological changes, clinical manifestations, diagnostic assessment, therapeutic and nursing management. The complications of pancreatitis have also been discussed. 4.2 Definition. Acute pancreatitis is an inflammation of the pancreas that occurs suddenly and usually resolves in a few days with treatment. Acute pancreatitis can be a life-threatening illness with severe complications and varies from mild edema to severe hemorrhagic necrosis. The severity of the disease varies according to the extent of pancreatic destruction. 4.3 Etiological factors. Alcohol abuse and gallstones are the two main causes of pancreatitis, accounting for 80% to 90% of all cases. The remaining 10% to 20% of cases of pancreatitis have various causes, including the following. Certain medications like corticosteroids, thiazide diuretics, oral contraceptives, NSAIDs, etc. are associated with increased incidence of pancreatitis. Exposure to certain chemicals, times certain metabolic disorders such as hyperparathyroidism, hyperlipidemia, times after surgical procedures on pancreas, stomach, duodenum or biliary tract, and after ERCP, times viral infections like post-mumps. Complication, Coxsackie B virus, calculus, hepatobiliary disease, times ischemia of the pancreas as seen after cardiopulmonary bypass, times in some cases the cause can be idiopathic, Fig 4.1, inflamed pancreas due to gallstone blocking ampulla. Pancreatic ducts through an open or distended sphincter of OD. This reflux may occur because of gallstones impacted at ampulla of Vater, atony or edema of sphincter. Trypsinogen is an inactive proteolytic enzyme produced by the pancreas. Normally, it is released into the small intestine via the pancreatic duct. In the intestine it is inactivated to trypsin by enterokinase. Normally trypsin inhibitors in the pancreas and plasma bind and inactivate any trypsin that is inadvertently produced. In pancreatitis, activated trypsin is present in pancreas. This enzyme can digest the pancreas and it also activates other proteolytic enzymes such as elastase and phospholipase A. Elastase and phospholipase A also plays a major role in autodigestion of the pancreas. Elastase is activated by trypsin and cause hemorrhage by producing dissolution of the elastic fibers of the blood vessels, and phospholipase A is activated both by trypsin and bile acids causes fat necrosis. Alcohol causes spasm of the sphincter of OD and leads to reflux of bile acids in pancreatic duct. Alcohol stimulates more acid production leading to decreased gastric pH, which in turn leads to release of hormone secretin by the intestine, ultimately stimulating pancreatic secretions. Thus pathological changes are because of premature activation of proteolytic and lipolytic pancreatic enzymes which are normally activated in the duodenum, which leads to autodigestion of pancreas. Fig 4.2, Flowchart of pathological changes in pancreatitis. 4.5 Clinical manifestations. Till the patient will complain of abdominal pain in mid-epigastric region radiating to back because of retroperitoneal location of the pancreatitis. Pain has sudden onset and is severe, deep, piercing and continuous. It is aggravated by eating and is not relieved by vomiting. Times na tilde c. Some people do vomit, but vomiting does not relieve the symptoms. Times low-grade fever, times decreased bowel sounds, times hypotension, times rapid heartbeat. A rapid heartbeat may be due to the pain and fever, or it may be due to compensatory mechanism in a situations. If a patient is bleeding internally, times feeling of lightheadedness or fainting, times intravascular damage because of circulating trypsin may cause areas of cyanosis and blue discoloration on the abdominal wall, times increased formation of canine peptides like kallikrein, bradykinin causes increased capillary permeability and altered vasomotor tone. Times hypovolemia can occur as a result of exudation of blood and plasma proteins into the retroperitoneal space. Times shock may develop because of hemorrhage into the pancreas or toxemia from the activated pancreatic enzymes. In this case, Turner's sign, bluish discoloration in flank, and Culler's sign, bluish discoloration in periumbilical region, are manifested. 4.6 Diagnostic assessment. Laboratory investigation of blood reveals increased level of following. Times serum amylase may elevate to levels greater than 200 UIL within 24 hours up to 7 to 14 days. Times increased serum lipase. Times urinary amylase may be increased to more than 3600 UDA. Times hyperglycemia. Times hypolipidemia. Times hypocalcemia. Times increase LFT, times increase WBC 1000 ml. 2 Diagnostic imaging tests, times abdomen X-ray, times CT scan, times ultrasound if biliary stone is suspected, times magnetic resonance cholangiopancreatography, 4.7 complications of pancreatitis. The acute and late complications of pancreatitis are given below. 4.7.1 acute complications times shock times hypocalcemia, low blood calcium, times high blood glucose times dehydration and kidney failure resulting from inadequate blood volume, which, in turn, may result from a combination of fluid loss from vomiting, internal bleeding, or oozing of fluid from the circulation into the abdominal cavity in response to the pancreatic inflammation, a phenomenon known as third spacing. Times respiratory complications are frequent and are major contributors to the mortality from pancreatitis. Some degree of pleural effusion is almost ubiquitous in pancreatitis. Some or all of the lungs may collapse, atelectasis, as a result of the shallow breathing which occurs because of the abdominal pain. Pneumonitis may occur as a result of pancreatic enzymes directly damaging the lung, or simply as a final common pathway response to any major insult to the body, i.e., ARDS or acute respiratory distress syndrome. 4.7.2 Late complications. Late complications include recurrent pancreatitis and the development of pancreatic pseudocysts. A pancreatic pseudocyst is essentially a collection of pancreatic secretions which has been walled off by scar and inflammatory tissue. Pseudocysts may cause pain, become infected, rupture and/or cause hemorrhage, and may press and block the structures such as the bile duct, thereby leading to jaundice. It may even migrate around the abdomen. 4.8 Therapeutic management. The objectives and details of therapeutic management is given in following subsections. Objectives. Treatment is usually focused on relieving symptoms and preventing further aggravation of symptoms. So objectives for the treatment are times relieve pain, times prevention or alleviation of shock, times reduction of pancreatic secretions, times control of fluid and electrolyte imbalance, times prevention or treatment of infection, times removal of precipitating cause, times preventing complications. 4.8.1 Conservative treatment, times medication for pain management using NSAIDs, anticholinergics and histamine receptors and antagonist to reduce pancreatic secretion. Times nil orally. No food or liquid should be given to patient by mouth for a few days. This is called bowel rest. By refraining from food or liquid intake, the intestinal tract and pancreas are given a chance to start healing. Times nasogastric aspiration to reduce vomiting and preventing gastric secretions from entering duodenum, which may stimulate pancreatic secretions. Times fluid resuscitation through replacement of IV fluids to maintain fluid and electrolyte balance, or fluid sequestration within bowel lumen. Continued fluid administration is necessary to prevent secondary organ dysfunction. Times F-place catheterization if necessary. Times CVP line care. Times may require early intubation and respiratory support. Times require meticulous critical care. Times prophylactic use of antibiotics. 4.8.2 Endoscopic cholangiopancreatography, ERCP, and surgical procedures. The following surgical procedures are performed by the physician. You need to understand this to be able to provide appropriate nursing care after lightly sedating the patient and giving medication to numb the throat. An endoscope is inserted through the mouth, throat, and stomach into the small intestine. The physician guides the endoscope and injects a special dye into the pancreatic or bile ducts that help the pancreas, gallbladder, and bile ducts appear on the screen while X-rays are taken. The following procedures can be performed using ERCP. Sphincterotomy, using a small wire on the endoscope. The muscle that surrounds the pancreatic duct or bile ducts is accessed and a tiny cut is made to enlarge the duct opening. When a pseudocyst is present, the duct is drained. Gallstone removal. The endoscope is used to remove pancreatic or bile duct stones with a tiny basket. Gallstone removal is sometimes performed along with a sphincterotomy stent placement using the endoscope. A tiny piece of plastic or metal that looks like a straw is placed in a narrowed pancreatic or bile duct to keep it open. Balloon dilatation. Some endoscopes have a small balloon that is used to dilate or stretch a narrowed pancreatic or bile duct. A temporary stent may be placed for a few months to keep the duct open. 4.8.3 Surgical debridement. Infected pancreatic tissue, abscess, or large areas of necrosis should be considered for early debridement. Percutaneous drainage of the pseudocyst is performed and drainage tube is left in place. Necrosectomy is done in case patient is not improving with the conservative treatment. 4.8.4 Nutritional support times. Initially the patient is on NPO status to reduce the pancreatic secretion. Decision about total parental nutrition TPN versus enteral feedings must be made. Patient with paralytic ileus secondary to the pancreatitis or abdominal complications require TPN. Enteral feeding distal to the ampulla of Vater is well tolerated. When patient's condition improves, fluids are allowed. Small frequent meals, which are high in carbohydrates and low in fat, are given to patient. 4.9 Nursing management. 4.9.1 Assessment. Subjective and objective data is obtained regarding past health history, medication, or surgery or other treatments. General and system-wise objective data is taken. General data includes following times ABC, times pain severity, relieving and aggravating factors, times nausea and vomiting, signs of dehydration and electrolyte imbalance, times impending signs of shock i.e. low blood pressure, tachycardia, times signs and symptoms of infection, times abdominal distension and tenderness, times bowel sounds. 4.9.2 Nursing diagnosis, times acute pain related to inflammation of pancreas and surrounding tissues, times risk for imbalanced fluid volume related to vomiting, nasogastric suctioning, NPO status, fever, shifting of body fluids, times imbalanced nutrition related to inability to ingest or digest food or absorb nutrients, vomiting, nasogastric suctioning, NPO status. Times ineffective breathing pattern related to abdominal distension, ascites, pain, or respiratory complication, times risk for infection, times ineffective therapeutic management related to lack of knowledge of preventive measures, diet restrictions, and restriction of alcohol intake and follow-up care. 4.9.3 Planning. Times reduce the degree of pain or relieve the pain, times maintenance of fluid and electrolytes, times maintenance of balanced nutrition, times maintain effective breathing pattern, times maintain effective therapeutic regimen. 4.9.4 Implementation. The nursing intervention related to various problems is given below, related to pain, times assess degree and nature of pain. Times administer pain medications as instructed for relieving pain, times promote pancreatic rest by NPO and NG suctioning, times semi-Fowler's position to decrease pressure on the diaphragm by distended abdomen, times bed rest to decrease the metabolic demands related to fluid and electrolytes, times check the color and amount of gastric aspirate. Times monitor vital signs i.e. BP, pulse, respiration and temperature, times ECG, times monitor urine output, times maintain intake and output record, times observe for the manifestation of electrolyte imbalance, times check blood glucose levels, times check for the signs of hypocalcemia, symptoms of TENI such as jerking, irritability, and muscular twitching times assess for a positive SOHS or true SOHS sign. Related to nutritional support times monitor weight and laboratory values times observe stool for steatorrhea times administer nasogastric feeds. Nutritional support is paramount and the decision about total parenteral nutrition TPN versus enteral feedings is made. Thus accordingly care is required times frequent oral and nasal care to relieve the dryness of the mouth and nose will add to the comfort of the patient related to breathing pattern times assess respiratory functions times provide comfortable position times if acute respiratory distress syndrome develops, the patient may require intubation and mechanical ventilation, so you need to assist in the procedure and provide care to the patient with ventilator. Related to infectio times observe for fever times chest physiotherapy and turning, coughing, deep breathing exercises and assuming semifowler's position to prevent respiratory infection related to ERCP and other surgical procedures times prepare the patient for the procedure and assist in ERCPI. Taking consent for the procedure, care of dentures, administering premedication if ordered, monitoring vital signs during and after the procedure and observing the patient for potential complications like perforation, bleeding, and infection times provide pre- and post-operative care in case of surgical procedure as learnt in your basic training times provide special wound care and pouch care times assess and measure fluid and electrolyte loss related to therapeutic regimen to prevent further attacks. You should advise the patient that he should times stop alcohol consumption and smoking times eat a diet high in carbohydrates and low in fats times should report immediately of any untoward symptoms e.g. constant severe abdominal pain, jaundice, high blood glucose level, steatorrhea. 4.10 Summary. Acute pancreatitis is an inflammatory condition of the pancreas characterized clinically by abdominal pain and elevated levels of pancreatic enzymes in the blood. Abnormal exocrine and endocrine function can occur during an acute attack. In patients with interstitial or mild acute pancreatitis, the gland returns to histological and functional normalcy after recovery. Endocrine function returns to normal soon after the acute phase, while exocrine function may take up to 1 year for full recovery. Depending on its severity, it can have severe complications and high mortality despite treatment. Therefore, nurses should not only manage these patients but also should advise them to prevent the recurrent attacks and complications. In this unit, we have discussed the definition, etiological factors, pathophysiology, clinical manifestations, diagnostic assessment, complications of pancreatitis, therapeutic and nursing management. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.